We will start today's topic. 52-year-old male patient who came to consultation on January 21 of this year due to photophobia in both eyes. He reported discomfort when driving at night and denied any medical or ophthalmologic history. Upon evaluation, the patient had a visual acuity of 20/100 in the right eye and 20/80 in the left eye. A slit lamp examination revealed cataract in both eyes, with the rest of the anterior and posterior segment showing no abnormality. It is worth noting that the patient had a prominent forehead. The patient was diagnosed with cataract in both eyes. The plan was to prepare for phacoemulsification surgery plus IOL implantation in both eyes. On August 14, phacoemulsification surgery plus IOL implantation was performed of the right eye. One of the complications encountered was constant iris prolapse through the main incision due to positive pressure. The iris was repositioned, but inferior atrophy was observed. Surgery was complete. The patient attended their first post-operative appointment on August 15, reporting male pain. Upon evaluation, visual acuity was 20/60 in the right eye with intraocular pressure of 13 with a deep chamber and 2+ cells, iridodialysis between 6 to 9 o'clock, iris atrophy, dyschorrhea, IOL in situ treatment was provided, and a follow-up appointment was scheduled in 3 weeks. The patient attended a follow-up consultation on September 9, reporting colored halos at night while driving. Visual acuity was 20/26 with intraocular pressure of 12. A slit lamp examination showed a D chamber with no cells. 3-hour iridodialysis, dyschorrhea, IOL in situ, and no abnormality in the fundus in examination. Diagnosis: pseudophakia in right eye, iridodialysis in right eye, cataract in left eye. Iris repair to right eye is scheduled. Here we have a photograph of the injury to the iris showing atrophy of the iris with disinsertion of the root of the iris from 6 o'clock to 9 o'clock. On October 12th, iris repair was performed with 2 vertical paracentesis in the reconstruction area at 6 and 12 o'clock. Modified suture technique with base-to-base suture, peritomy performed to tie and close suture with 10-thiopolipropylene, anterior chamber with moxifloxacin and aeration of wound. The pressure was complete without complication. Here we observe the moment when the first suture was placed for the formation of the pupil using the modified suture technique. These steps are illustrated in the picture. The second step will then be the direct repair of the iridodialysis, in this case, using handbag technique. This technique works best for iridodialysis of 3 o'clock hours or less. A side port is rated 3-4 o'clock hours away from the dialysis. A 10 polypropylene suture is passed through the iris root and pulled through a scleral tunnel. The other end of the suture is passed similarly. A knot is tied and rotated into the anterior chamber. First, postoperative day visual acuity 2200, intraocular pressure 11 on the slit lamp examination, deep chamber, cellularity, 2 crosses, blood traces, temporal iris atrophy, pupil with slight dyschorhea, IOL in situ. Treatment with topical steroid and side antibiotic therapy. Here we observe the first post-operative date of the iris repair with same areas of iris atrophy, deep anterior chamber, and a firm pupil with slight dyschorhea. The last evaluation was conducted on October 27 during the follow-up appointment, where the patient presented visual acuity of 20/30 with intraocular pressure of 15 on a slit lamp examination. The deep anterior chamber had no cellularity, temporal iris atrophy, the pupil slight dyschorhea, and the intraocular lens was in situ, appointment in 6 months. Here are the photos of the last evaluation carried out on October 27. The patient had no complaints. The topic to discuss today is about possible causes of iris prolapse and its management. When we have an iris prolapse, we shall keep in mind what the possible cause could be, including overfilling of OBD, short or long incision, posterior entry near to root of the iris, elevate intraocular pressure, narrow anterior chamber, elevated intraorbital pressure, floppy atonic iris, small pupil. Let's mention some techniques for managing iris prolapse. First step, identify and treat the underlying cause. We need to check if we have positive pressure, adjust the blepharosphere, and ensure that the patient head is positioned higher than their feet. We should ask the patient if they are in pain or if they are taking any medication, such as anti-prostate drugs. We should actually inquire about medication beforehand to be prepared for this situation. We need to check
pressure, whether it is more.
if we have positive pressure, adjust the blepharosphere.
The medications he's taking on,
or
and he replied
ask
that he's
if
just taking
take any medication.
antihypertensive, nothing else. I'm using adrenaline just to hope that the pupil dilates.
There is high incidence and association of intraoperative floppy iris syndrome with tamsulosin, as well as with finasteride, losartan, benzodiazepine, duloxetine, and antipsychotics, but especially with tamsulosin. Another techniques for managing iris prolapse use epinephrine to relax the iris sphincter in case of a shallow anterior chamber, applying enough viscoelastic, or if there is an access, remove it.
Behave just like an IFIS and I'm going to have a problem. I'm checking the pressure now, whether the pressure is high. So is this a soft eye or a hard eye? It looks like it is not at all a hard eye, it's a soft eye. So maybe just the iris is misbehaving. And that was my impression. So my mind is ticking now. What strategy should I go in? I don't know whether I'll have more problems as I proceed with the surgery, or should I take any precautions now itself? I have decided.
Use a pupil expansion, rinse, or a pupil retractor. In the video, we can observe the placement of iris retractor in a patient who presented with floppy iris syndrome. This way, we can keep the iris more stable. In this case, we see that a pupil expanding ring was used to prevent the constant prolapse of the iris, which we can also use in case of small pupils.
Allowing iris capture with the medial and lateral scrolls of the ring. As three facets of the ring are already nicely in place, the proximal aspect of the ring can easily be manipulated into place. I have used various hooks, including a Lester and Kuglin, but I have found the Malyugin manipulator allows for the easiest grasp of the ring. Once the intraocular lens has been inserted and centered, as we are doing here, the distal scroll of the Malyugin ring can easily be disinserted. The Malyugin manipulator is now reintroduced into the eye. The proximal scroll is easily grasped and disinserted from the iris. The inserter device is then placed into the eye. The proximal scroll is ensnared, allowing for seamless removal with minimal iris manipulation.
Okay, in this case, Malyugin rings were used. Comment: conduct a thorough clinical history and pre-surgical evaluation. Avoid incisions that are too anterior or posterior. Use topical NSAID 3 days before surgery for patients with a history of intraoperative floppy iris syndrome. Ensure proper hydration of the main wound and place as usual if needed. Always address the underlying cause for better control and outcomes. Thank you very much.
Brenda, I have a question, Brenda. You mentioned that he had a prominent forehead and the iris defect was inferior. What do you think about that?
Yeah.
The incisions of the phaco were from a temporal approach.
Okay. It was temporal approach?
Yep.
Oh, okay. So thanks. It was a nice case. Nice techniques, and especially the repair was very well done. It was a great job. I think it was you, Pamela. You were doing that, correct?
Yeah, I was just gonna add a comment on the let's see if that works there. Yeah, just gonna add a comment. That was a great case.
Mhm.
I was really impressed with the repair also, how you took that dialysis and repaired it. And I'm interested on the when you had the this little tear here, you made one suture here, and then you came across the eye to pull this part down to here. Is that how that worked? Or was it a loop with two like two sutures passing through that wound out here?
So, oh, this is cool actually. So, we did the surgery with Pamela under my supervision. So, yeah, there were like two sutures passed. The modified suture through the this side, and yeah, we have like 3 side ports. I believe, and 4 actually. Here there was like the peritomy. No, we didn't have a side port here. So we had like we used the 27 gauge needle to feed the suture coming the 10 suture from this side, if that makes sense. But
Yes.
already when we had to modify to zipser sutures to get the pupil closer, and then we realized that the pupil had the shape of a drop, and Pamela passed a third suture.
Yeah, but
around.
something that Claudia maybe not mentioning and it happened to us is that we at the beginning we thought that we were just gonna close the pupil like with Sipser with modified Sipser, but while we were trying just to close the pupil, actually the dialysis like start like getting bigger to one side, so we decided to pass the other sutures, like aerial dialysis repair through the sclera to close that part.
Mm.
Oh, I see. Yeah. It looked beautiful. I was just gonna add one other way to if you have a closure and you're trying to, sometimes what we'll do is if you're not comfortable with the Seepser technique, is I'll pass a suture needle through here, pick up this iris, and then come out here. And then another way to tie that is actually to have a little small paracentesis right here. And then you can actually go into like a hook and pull that thread out through here and this thread out through here, and then tie them, and that closes. That's a different way to do that. But I think the way you did it looks really beautiful. And is that a proline suture? Was that what that was?
That's right.
Yes.
And I'm wondering if anybody's seen problems with proline degrading, and if anybody's used, we have some Gore-Tex sutures down here too. I'm wondering if those have been used at all.
I haven't used them yet.
I think they're 8.0 Gore-Tex, though, maybe. Yeah.
I mean, if I could just say, I noticed your needle, the long needle, was quite curved. You could have straightened it out a little bit. You can straighten out that needle so you wouldn't have to balance it like that, because you were.
Yeah.
Did you notice that?
Yep. Yeah. I didn't thought about that.
You can straighten that needle a little bit with your
Okay.
needle holder, and it just helps you out with the angle of
Right.
injection.
Yeah, you're right. Thank you.
the
I
other-
didn't thought about that before, so I will
Yeah,
do it
just-
next time.
Yeah, just a little tip there.
Thank you.
Yep.
May I add just one more observation? We were talking about this here locally. If here's the cornea and you have your iris here, I think if you go in with if there's a big brow up here, your incision might look a little bit like this.
Mhm.
Whereas if you had, it's something the incision you had, because you're temporal, you can actually approach it a little more like that, or like this. So you have a little more of a, you can get this, you could even kind of come up in here if you felt like you were getting too close to the iris root. And that's a way, it seems like you're less likely to get a prolapse if you're coming in temporarily with that flatter, longer self-sealing wound as compared to that wound. But I think that depends on what the approach angle is.
Right. Okay.
Yeah, it's really nice.
Thank you.
Pulling is that a case pulling that you do much of in your cornea practice, where you're getting iris lesions to repair, and how do you do it?
Yeah, I often use a similar technique. I mean, recently we have some products that I've been trying out that I really like, artificial iris implants that are pretty cool. But yeah, typically I do that exact kind of technique. I use a double arm Prolene when I'm trying to repair neurodialysis, and do that mattress suture that kind of brings it out through the sclera like they demonstrated. And then I just go across like you did with mechanical sutures and repair the iris. But it is nice now that to be able to have a prosthetic available in the US, because it just makes that a lot easier.
When you do that, Roland, do you do a scleral groove to bury the knot?
No, I usually either leave the suture ends long and just leave them underneath the conjunctiva, or if it's a mattress suture, just kind of rotate it into the tunnel of the scleral, the needle pass in the scleral tunnel. But oftentimes, like I said, using those Prolenes, I'll just leave the suture ends long and lay them down on the sclera and close the conch on top, because if the suture ends are short, they kind of poke out to the conjunctiva. But if you leave them long, they often lay down flat against the sclera, and that way you don't have to bury. If you can't rotate knots, you don't really have to. Just leave them long and they stay underneath the conch.
It's really clever. I've never done that pulling. That works well. Just leave them. How long do you leave them? Long, 2 millimeters?
Yeah, leave them a couple millimeters long, and they just kind of lay there flat, and they don't bother the conch. You can see them, obviously. So if you don't like the way they look, it's different. But if you don't mind it, or if they're superior and inferior, they're covered by the lid. But yeah, you can leave them long, and they just stay there, lying flat against the sclera.
That's interesting.
I think the other things I would mention is intraoperatively, because, what do you do? What are the steps? Often talk to residents. I think the most important thing to, like they mentioned, is make sure the eye is really soft. And if you have a firm eye and there's iris prolapse, it's useless to try and put the iris back in without lowering the pressure first. So the absolute first thing you always got to do is make sure, if you need to, make another paracentesis and let some of the viscoelastic out, so that you can lower the pressure. The iris should be very soft before you try and reposit iris. And typically I'll make a paracentesis so that I can sweep iris into the wound, the main wound, rather than pushing it with like a cannula, which is our tendency. Because if you're just pushing the iris right back through that main incision, it usually comes right back out and you're kind of poking holes in the iris, as opposed to using a sweeping technique. Make another paracentesis and just bring the cannula in, kind of sweep the iris back. It's a little bit more gentle and less likely to cause iris trauma or iridodialysis.
But the last thing I would add on that is if you're once you reposit it, if you have a lot of case left, putting a little blob of viscoat, right, just a small spot right there will keep it, or Helon GV, or there's another one that's like that now I've seen used. What's the other one that's replacing GV? Helon 6 or something? I don't know what it is.
Yeah, Helon 5 is a real dense one.
Yeah.
But yeah, something to keep that iris down. That's a good point, because it'll sit there for a while you're doing the rest of your phaco.
And then the other option is just to put it back in and abandon that wound and make another wound somewhere else. If you're really struggling with it. That's a great case, Brenda.
Andy, would you stop and put some hooks just in case, just if you still have a lot of cataract to finish and it's really small pupil, or the pupil is coming down, and and you have a big cataract, would you stop and just put hooks or something? Deal with the iris?
I think that's a nice way to stabilize a constricting pupil. If you have some case left, you got to do something, right? You got to either put some type of a iris support system in there, and probably phenylephrine may not be what you're looking for.
Do you have a preferred? Do you like hooks or do you like Malugan?
I think if you have a really, I guess it's really floppy. If a floppy iris, I guess I don't think of Malugan rings being that helpful. I mean, if the problem is a floppy iris, I think I'm going to deal with the iris and do the other techniques that we talked about. I guess if it's a small pupil, I'd probably prefer a ring. What were you going to say, Scott?
Well, one strategy I've seen recommended with iris hooks is to put a paracentesis under your main and put a hook in there and hook the iris, and thereby preventing it from prolapsing through your main. I'm not sure if anyone here has tried that or has thoughts on that.
Yeah, I typically do that especially when I'm doing extracapsular surgery, is if I see iris prolapse because the tunnel's short, I'll make a paracentesis underneath the main incision and put a hook there just to keep that iris from prolapsing. It's really used, I really need it in phaco, but for sure for those extracap cases where the iris is coming out of the main incision, and I think that's very helpful actually. And if we're using these hooks,
this would be your anatomy here, like that.
Slides too.
Yeah, that pair has to be pretty much in the sclera, because it's got to be near the iris root. So it's about 1.5 millimeters posterior to the limbus. But that'll keep that iris down and flatten underneath your incision so it doesn't prolapse. Andy, have you played with the new Human Optics iris prosthetic from VO Ophthalmic?
Not at all. I've only done one, and it was the Morcher.
Oh yeah, it's pretty cool. We just started playing with it. It's a nice device. It's definitely looks really, really nice, and is easier to use, I think, than a lot of the other products that we've tried in the past. So I think it's something that's going to be popular in the U.S. now that's FDA approved, and they have CPT codes and all that stuff for it in the new.
So in this case, does that go in the bag or in the sulcus?
If you're doing the phaco at the time and you're having iris defect, you can put it in the bag. But You can also go back secondarily afterwards if the patient's pseudophakic and put it in the sulcus. There's two types. One has fibers in it, so you can also suture it if you don't want to just put it in the sulcus or put it in the bag. There's a second type that has like, it's a little bit denser and has fibers in it, so you can put a suture through it and you can suture fixate it as well.
That's cool. We'll learn about that next time.
Mhm.
Yeah, I'll get some cases together.
All right, everybody, thanks.
Thank you.
I miss you guys. I wish I was there.